Good morning, everybody, and welcome. Today, our speaker is Dr. Rakesh Dayaram. Dr. Dayaram attained his bachelor's degrees in medicine and surgery from the University of Pretoria in 2005. He then completed his internship at Piet Retief Hospital in 2006. His community service year was spent in Witbank, where he spent as much time as he could in the surgical department. He worked as a medical officer in the surgical department for a year, awaiting a position as a medical officer in the ophthalmology department. Dr. Dayaram underwent intensive and thorough ophthalmic registrar training in the University of the Wiwatersrand registrar circuit. He spent most of his time at St. John Eye Hospital, but also rotated through Charlotte Maxeke Johannesburg Academic Hospital, Helen Joseph Hospital, and Lenasia South Community Health Centre. He received his fellowship from the College of Ophthalmology, South Africa in 2015. He then further completed a dissertation entitled Visual Acuity Outcomes Achieved Post-Cataract Surgery at St. John Eye Hospital in order to obtain a Master's in Medicine degree in ophthalmology. Today, Dr. Dayaram is a skilled ophthalmologist known for his dedication to patient outcomes with a commitment to excellence in his clinical practice. His holistic approach to patient care ensures that he addresses the unique needs of each individual, making a meaningful impact in their lives. Thank you so much for being here and presenting to us.
Okay, thank you, Dr. Cordino. Today I decided to present diabetic retinopathy. It's a horror show. 95% of all diabetics that enter my rooms don't understand that you can get retinopathy from diabetes. They know you can your eyes can get damaged, but not precisely how. They just think it's cataracts most of the time. So I think there's a lot of knowledge that needs to just be spread out, and people need to be aware that retinopathy is present and it's quite serious. So anyway, diabetes mellitus. Mellitus comes from the word sweet honey. So it was first identified around 300 to 250 BC. It's characterized by the sweet properties of urine. Luckily, we don't need to taste urine anymore to figure out if a diabetic is, if someone's diabetic, unless you enjoy the Gilpin family whiskey. This whiskey is created by Patricia Gilpin's, with use of Patricia Gilpin's urine. She's 73 years old, as you can see on the bottle. And they've made whiskey out of this, and it's available on the market, I believe, in Scotland. Today, diabetes is one of the 10 top most prevalent and most important non-infectious causes of morbidity and mortality worldwide, with 12% of South Africans being diagnosed, which is 7.5 million people in South Africa, and 1 in 1,000 children being diagnosed with type 1 diabetes. So, diabetic retinopathy. Why diabetic retinopathy? It's got huge socioeconomic impact on your patients. These patients progressively lose their vision, and as a result of their loss of vision, they're not able to inject themselves anymore with insulin. They're not able to see their medication anymore. They start being ineffective at work, and they can lose their jobs. And because they lose their jobs, they can't pay for their healthcare costs. So it's a vicious cycle. Diabetes causing retinopathy, causing loss of job, causing loss of income and medical aid and poor health. Then they don't get the healthcare that they require timelessly. It can affect their daily living activities. They can't enjoy things that they were able to enjoy previously. So, and social interactions, playing golf, playing sport in general. So it really is a big problem in my practice. And once it's advanced, it's very difficult to help them regain their vision. So the Ophthalmic Society of South Africa recommends yearly screening for all diabetics, with type 1s starting 5 years after diagnosis. However, if you're not sure, you can send them through for dilated examination at diagnosis, and then we'd probably see them 5 years later. And type 2s at the time of diagnosis. And pregnancy should be just when you know you are pregnant, so not at conception exactly, but and thereafter every trimester. Right? In the age group of the 25 to 74-year-olds, it's a leading cause of permanent vision loss. So in 2030, 191 million people will have some type of diabetic retinopathy. And 56.3 million of these people will have vision-threatening diabetic retinopathy. There's a study that shows that at 20 years after diagnosis, 99% of all of your diabetic patients will have some degree of retinopathy. Your type 2 diabetic patients, sorry. And 60% of your 99% of type 1, sorry. And 60% of your type 2s will have retinopathy. So if you have a type 1 at 20 or 15, by 35, they will have retinopathy. That's really, really scary. And what can you guys do about it? Everyone knows that strict control of the HbA1c is very important. And you can see the highest benefit from strict control of HbA1c is a 37% reduction in risk for microvascular complications. So that's where I fall in. So what are the risk factors for progressing to diabetic retinopathy? Obviously, everything that's uncontrolled in these patients, the blood glucose levels, HbA1cs, the dyslipidemia. Ethnicity, we know that certain groups in South Africa are more prone to developing diabetes, your Indian, your Black patients, and smoking is always a problem. I guess vaping is probably also going to fall into that category. Right? What do we look for in diabetics when we perform an examination? Normal stuff. We start off like a medical student will tell you. Let's take a history. History, we perform visual acuity. We just check what's their vision on the vision chart with their glasses on, contact lenses on, eye pressures, check if they have extraocular movements, which are normal. And we're looking for abnormal blood vessels on the iris, which is very important. This is a late complication of diabetic retinopathy, rubiosis. Cataracts, everyone knows that diabetics get cataracts, so that's not too difficult. And floating things in the eye, vitreous cells. So basically, you got to take that history and you got to decipher it. Patient's history, patient will complain of decreased vision. They just don't see as well, complain of hazy, blurry vision, or Afrikaans patients will say, "Dis is vaal of waserig," and that's when you start worrying about possible retinopathy. Metamorphopsia, basically distortion in their vision. So when they're reading something, as they are reading, certain parts of the word disappear or get magnified or get minimized. That's metamorphopsia. So if they're looking at lines in your office and if they see distortion of the lines, this may be due to diabetic macular edema, actually. And vitreous floaters. Sudden onset of vitreous floaters could indicate a vitreous hemorrhage. And a visual field defect, sudden onset of visual field defect. And obviously, the other thing that you can, patients will tell you, listen, I have a cataract because I've seen a cataract in my dad's eye or something like that. So what do? We dilate their eyes with tropicamide or madrasol, put them on a slit lamp, and this is what we see. If your patient doesn't have any diabetic retinopathy, this is a nice healthy retina. The vasculature is nice and straight, and you've got a nice even background, no complications or problems in this eye. Right? Diabetic retinopathy can be divided into two parts. You get the non-proliferative and obviously the proliferation of new blood vessels. That's what proliferative part is. So you can see on the left, everything until they grow blood vessels is non-proliferative. The moment they start growing blood vessels in their retina, that's considered as proliferative. So, it's the exudates, aneurysms, all of those things we learned in undergrad that we somehow remembered vaguely. Non-proliferative retinopathy, it's classified into mild, moderate, and severe. Basically, what I tell my patients, diabetes is a vascular illness. It affects the blood vessels in your body. We know it's got to do with sugar and insulin, but that high glucose level affects the blood vessels in your body. So the cells that are tightly packed that make up the wall of your blood vessel start to get gaps between them. And those gaps cause bleeding and leakage. It will leak blood, it can leak water. When you get leakage of water from those walls of those blood vessels, you can get swelling at the back of the eye, basically edema. patients know what swelling is of their ankles. Also, I explain an aneurysm to them and I compare it to a tire that's hit a pothole and bubbles up on the side. That's exactly what an aneurysm is, and patients relate quite well to that. And a lot of them don't know that you can get all of these types of problems in their retinas. So that's how I simplify it and explain to the patients with regard to how early diabetic retinopathy and non-proliferative retinopathy. These are the classifications of the stage. We generally don't do anything. On this side, what I do, I'd say, pick up the phone, Dr. Engelbrecht or Dr. Cordino, please help me with this patient. They need stricter glucose control. Can you admit, can we work up these patients so that they don't progress to proliferative retinopathy? So that's the most important thing. It's actually strict on your side. It's, keeping them as strict as possible. The toughest and hardest thing in the world, actually. Proliferative. How do I explain proliferative retinopathy to them? We know it's leakage of capillaries and occlusion and retinal ischemia. What happens, what I tell my patients is, with narrowing of the arteries in their eyes, the retina gets choked. It doesn't get enough oxygen. Because of this low oxygen concentration that it's receiving, the retina starts to make this evil person here, VEGF, vascular endothelial growth factor. So everyone says, yeah, VEGFs are evil. So vascular endothelial growth factor is what gets produced by the retina when you don't have enough oxygen reaching the retina. And that VEGF starts to grow new blood vessels in the eye. And those blood vessels cause havoc. So here's a classification. We kind of remember this vaguely from medical school. Let's move on. That is dangerous. That's horrible. You can see these patients have multiple new blood vessels growing in the eye. This retina is completely ischemic because of all those blood vessels growing on the disc, around the disc, around the. Can I use my cursor? Yeah.
You should go.
Oops. Oh, there we are. Yeah. Flame-shaped hemorrhages, dotted blot hemorrhages, new vessels. You can see this loop of a vein here. And as you can see, there's also a little bit of hypertensive retinopathy here. So this person has high-risk progressive proliferative diabetic retinopathy. This person needs urgent treatment. So from this, they progress to this. This person suddenly can't see. He was busy working on his laptop, and now there were a few floating things in front of his eye, and it can't see. And if you don't start treatment here aggressively, they go to this. This person will not see going forward. This person's blind. Diabetic retinal surgeons can perform wonders in retinas, but this cannot be fixed easily. Sometimes these diabetics go for past plantar vitrectomy and the retina gets replaced and it starts to look much better. So the surgeon feels happy that it looks good, but the patient sees nothing. The retina has been ischemic for months, sometimes years, and function is definitely affected. So it's really, really a horrible problem. Other things that can cause conditions that look like diabetic retinopathy is anything that causes neovascularization. So conditions that cause ischemia of the retina and cause neovascularization of the retina and the iris. So once you have those new vessels, let me go back here. Once you have these new vessels growing from the retina, they grow forward, grow over the ciliary body, and grow into the iris. When it grows into the iris, it grows into the trabecular meshwork. It occludes their drainage angle, and they get huge pressure spikes. And once they start getting these huge pressure spikes, it's very difficult to control. They end up getting glaucoma treatments, surgeries, valves put in their eyes, and all kinds of things done to try and save their eyesight. So if you pick it up early, you can help prevent progression of the condition and halt it. There is a stage where diabetic retinopathy actually burns out if you've treated it sufficiently. So ophthalmologists like our toys. Here are some of the toys that we use. The most useful diagnostic toy and easiest to use for most people even physicians, is the retinal camera, retinal fundus imaging. So this is a retinal image of a healthy retina that I showed you earlier on. And we like to sometimes, well, in the past, we used to do this a lot. Fluorescein angiogram. So you take a patient, you cannulate them, and we inject fluorescein into them. And then we take numerous pictures of the eye for the first half a minute as the fluorescein is flowing in the arteries and veins and so on. Sometimes these patients get nauseous, so you must just have a bucket nearby from the flashes. And in the image on the right, let's see if I can get my mouse working again. Oh, there we are. So that's obviously the healthy one. There's no leakage. On the image on the right, you can clearly see that there are areas of capillary fallout. So those are ischemic areas. And each little star-like area is actually a macroaneurysm. And then the blurry areas are areas where they are leaking through the arteries. And that's the macula. So this is causing macular edema over the macula. So this was very useful. We still use it, but not as much as we did in the past. Then optical coherence tomography. This has changed how we treat eyes and how we manage patients, and also we've then needed to use the fluorescein angiogram much less. OCT is basically, it gives you almost the equivalent of a sonar type of an image of the macula, retina, and of the optic disc. So you can see there's a little bit more to the anatomy of an eye than what people think there is. Right? This is a healthy eye, and this is macular edema from diabetic. So these patients are going to get that metamorphopsia. And what do we do to treat these patients? Firstly, that's where you guys come in again, systemic control. Systemic control is the keystone or cornerstone of management of any diabetic complication. If they have good systemic control, they don't progress to have these complications that easily. On our side, firstly, management of the macular edema. Back in the past, which is about 20 years ago, there wasn't much we could do. We do a fluorescein angiogram and try and target the areas of leakage with laser. There you run the risk of actually lasering the macula, and then obviously the patient loses vision due to iatrogenic causes. And because of studies that have found that VEGF was a culprit, we then discovered that there are anti-VEGF drugs available to us, and many studies have been performed that show that injection of anti-VEGF drugs, like Avastin, all medical aids advise Avastin as first-line treatment. These patients need to be injected every 4 weeks for 3 weeks, and it's per eye. So if both eyes have retinopathy, both eyes need to be injected. So Avastin is usually the cheapest. It's about 650 Rand for the drug. And then if Avastin is insufficient or if it's inadequate in clearing up the edema, we then work our way up to Vabysmo or Vaseek. That's how you pronounce that word, Vaseek. Right? The active ingredient is called bevacizumab in the Avastin, ranibizumab, and faricimab. In case you're wondering about the pronunciation of those words, very difficult to learn initially. Other agent we can use is Ozurdex, which is a dexamethasone implant. It stays in the eye for 6 months, and this can be done also in the rooms. This is how it's done. Patient is draped, it's cleaned. The person here doesn't actually have a proper syringe. This volume is huge for the eye. It's actually as much volume as the entire eye is. We would just inject 5 insulin units into the eye. While your patient's awake, we just ask them to look down, anesthetize them tremendously. We give them Erbanol. We put in a hell of a lot of numbing drops just to see if they feel any pain. When it feels like you're touching your eyeball with your index finger, that's when we inject, and then they don't feel anything. Get up, and then they walk home. And I go and have a cup of tea. Right?
Tea.
Right? So this is done routinely in my rooms daily, a few times a day sometimes. Then proliferative diabetic retinopathy. So the gold standard is laser. There was a prof that asked me in my exam, how effective is laser for diabetic retinopathy? And he asked, is it more effective than a condom? And the answer is yes. It's 100% effective if you perform enough laser. So basically using argon laser photocoagulation, and you are devitalizing the retina, which is a nice term nice way of saying basically you creating tiny little infarctions in the retina. So eventually you have enough of the peripheral retina devitalized. That retina doesn't need oxygen. So oxygen isn't stolen from the central peripheral retina, important macular area. Then your VEGF gets down-regulated, and the new vessels disappear. So that's why it's very effective. You can only perform 1,500 of these shots per session, and sometimes patients need up to 6, 7, 8 sessions. So this person has probably very little peripheral field of vision to try and get rid of all those new vessels that are there. Vitreous hemorrhage is another problem, another way patients present. So sometimes patients present with floaters and sudden decrease in vision. There, you usually can't even see the retina. So when you can't see the retina, you can go ahead and inject them with anti-VEGF agents, which helps to clear up the vitreous hemorrhage. And once you can see the retina, you start lasering them. You can see this person's got quite a good peripheral retina to laser enough. Yeah, we just perform laser on the peripheral retina, and then hopefully it helps get rid of all of those new vessels eventually. Right? And then also surgery falls into this into management of the diabetic patient. Usually you go in a patient like this, or one of those previous images, the one with this, to clear up all of the blood that's there. Form laser, put some laser in the eye. So retinal surgeons do 2,000-3,000 shots of laser while they're inside the eye, and remove membranes that are formed on the retina. So you get these membranes that form on the retina, and then they pull the retina off, creating a retinal, they put it off the choroid, creating fractional retinal detachment. It's not the same as a retinal detachment that you would get from a hole in the retina. This one's much tougher to fix. These membranes are horrible, and they keep many a surgeon seated on that chair for hours on end. And then after laser, we sometimes put in some heavy gas or silicone oil to keep the retina attached to the eye. And this is what it looks like. So on the left, you have fast planar vitrectomy being done. There are many ports on the eye. This one's infusing fluid into basically it's saline into the eye. Here he is got a light probe, so you can see what's happening in the eye. And this is a vitrectomy probe. So the vitrectomy probe, this is the light probe, and this is a vitrectomy probe. So this is what it looks like. That's what's happening, and this is what he sees. Here you can see the surgeon has some forceps here, and he's busy peeling a membrane that's on the retina. So that's basically diabetic retinopathy, and this is the Eye of God nebula. So I wonder who's his ophthalmologist. Thank you so much for your time. Really appreciate it. Thanks a lot.
Thank you. It's clear that some people hobbies to watching horror movies. But it's quite a very nice, interesting presentations. So in the past, I remember quite when I was still on my early days, there was quite good link that you could actually screening for diabetic retinopathy just by sending urine, microalbumin. When that's positive, when they have a bit of urine albumin, which tells you diabetic retinopathy, the patient 99% of chance of diabetic retinopathy. So probably it's very good for people who know ophthalmologists. So then we come indication, say send the patient to ophthalmologist immediately. And that's for me, that would be the perfect thing. And I also know that some BPs in the quad one, the BP was in Piet Retief East, they do have a machine that actually when they come diabetic in, they can actually take a picture of the retina. And that's so now I think the technology, everything actually has improved. And ideally by now the patient should be reaching to ophthalmologist much more earlier than actually reaching to the other side of the eye. I mean, yes, no offense, but I think that injection in the eye, it actually keep me away from you. It's not very scary.
It's not painful. It's really not painful.
I know, but
my patients tell me. Everyone's afraid of it. Everyone's afraid of it for the first injection. So we'll give them some Urbanol and we really take our time to ensure that they're comfortable and sufficiently anesthetized. But after the first injection, they somewhat look forward to it because they can see. The problem is the regularity of the injections. You do need to keep on getting those injections. Sometimes it's every 4 weeks. You can extend it to every 4 months with Vabysmo. But yeah, that becomes a problem. You want to, in your younger diabetic with retinopathy, rather inject because you don't want to devitalize in the retina and create a tunnel vision. Yeah. Another way, what I also think of diabetic retinopathy is it's a snapshot of what's happening in their bodies. So if there is some form of retinopathy happening, there are problems elsewhere.
We already have the microalbumin here, so it's going to affect your.
But just quickly before we do, I think what you talk about the anti-VEGF. Yeah. So you mentioned, I think you make a mistake there. You say after 3 weeks, actually, I think after 3 months. You mean 3 months, isn't it? For the every 4 weeks for 3 months, isn't it?
Yeah, every 4 weeks for 3 months.
Yeah.
Sorry about that. Yes.
Yeah. So
For
just
3 months.
that,
Yeah, and then thereafter we extend it.
Yeah. Okay. So you have to
yeah.
come in for every 4 weeks for 3 months, okay?
And then thereafter, it depends on how often you need it. So we try to extend the time between injections. Vabysmo and Vizik have the largest duration between injections. So medical aids pay for this with motivation, and if you've produced enough evidence to show that Avastin hasn't been effective enough.
How young is your youngest patient that you can start this with? Because
Well, obviously the kids, you mean the injections?
the injections, yes. Because they need it sooner, especially my insulin dependent diabetics.
Yeah, these drugs are injected into preemies that develop retinopathy of prematurity in theater. So Avastin's injected into premature babies that develop retinopathy of prematurity, because in those patients they also get proliferation of blood vessels, and to stop the neovascularization, they get injected in theater with 5 units.
So the moment you need it,
So
even if
if you need it, you can. Yeah, kids. We don't usually really get kids with retinopathy easily, but I guess you can take them to theater. I haven't had any. I guess you can take them to theater if need be and inject them in theater. Yeah.
I just wanted to, that one slide that you showed about that one study, I think it was a bit earlier. I thought that type 1 diabetics have less complications. I think you said after 20 years, 99% of them.
Yeah.
So
I was also surprised with that.
Yeah, because you pick up type 1 diabetics earlier, so you control their sugars in your practice.
Yeah.
Do you have a lot of type 1 diabetics?
Not as many as type 2. I had just a few.
Yeah. You see, because by the time type 2 diabetics, you say they already have a lot of complications and other.
I think maybe what they mean, with the problem. Yeah, with the type 1 diabetic, normally they have in the first 3 years, they have in honeymoon phase, where their sugar is really nice, well controlled. But then after that 3 years, they do struggle with the sugar control. And that's why I think most of type 1 probably at 20 years makes sense that actually the rate of complication increases, because they, at the beginning of their diagnosis, they definitely no complication at all. So maybe just
it gets
more to do with the
exponentially.
control, and I mean, you're dealing depend also the age that get controlled. Most of them probably, if they can control a younger age, probably let's say by age 15, 16, most of the time complication will set in because remember they haven't lied. There's so many things happening, and they might not control it properly as like type 2. I think perhaps that could have been the reason. You know, I'm not sure. Leanne, what's your opinion there?
Yeah, I mean, I agree with what you're saying. I agree. I have a separate question. It's a practical question. It might be an easy one for you, but I see it quite often in like newly diagnosed diabetics, like say they come in with a DKA or something, or they were just very poorly controlled and in hospital, and it's often typically the ones that just got insulin on. And it's like once they go home, suddenly they realize, okay, but my vision is blurry.
Yeah.
And then I get a phone call to my office saying, I can't see. My vision is now blurry. And my experience is that most of them, once things settle down and even out, it all, it corrects, it's better, there's no issue. And they're like, wow, I'm fine.
Yeah.
But I have difficulty, obviously, when I get the phone call to distinguish between when should I be worried?
So, so when you get sudden strict control of diabetics glucose, they do get blurry vision.
Yeah.
I've seen some of those patients of yours. You examine them, you don't see anything wrong. It's thought to be micro thickening of the cornea, and they kind of settle after a few weeks. So they do need to be just reassured that this can happen when you suddenly control diabetic strictly. They also can progress to retinopathy sooner if you have a patient who was having blood glucose levels of 25, 30, and suddenly they're now under 7, under 8. They can progress to retinopathy sooner though. So that initial time period, it's not a bad idea to warn them that this you may get blurry vision for about 2 to 3 weeks, which will resolve. Which will resolve spontaneously. So it does resolve spontaneously.
But I think Leanne, when the said, I'm sorry. So obviously once they come with hyperglycemia, I think ideally you need to make sure that they need to see ophthalmologist if you don't have any of these calls. And then at least if it happened at home, then you can reassure them they already know that it's clean.
Look, out there, screening can be done with your cell phone. There are devices where, well, first you're going to have to install some dilating drops like tropicamide in their eyes. And you attach this device to your phone, your iPhone, with a lens, and you can actually take an image of the retina with this device. And it's a 3D printed device. Let's see if I can quickly. I'll show you here. I'll show you an image of what it would look like. And on your cell phone, you just take an image of the retina. That can be extremely helpful. Also as a screening tool. But if you're not certain of what you're seeing, then by all means, rather refer. Let's ensure that they get the treatment soon and early, and understand that they can get retinopathy also. Because patients don't know that they can get retinopathy. They know that they can, have amputations, they can have strokes and heart attacks, but they don't know that they can really go blind from diabetes unless you've had a family member that has diabetes.
Just go back to that other picture that the uncle wants to see about the whiskey.
I'll make that for you.
So Patricia Gilpin is the grandmother.
Oh God,
and James Gilpin started this distillery. So Patricia is 73 years old, as you know, and they have many diabetics donating their urine for this whiskey production.
And I can't see the reason for the sugar, because what's wrong with Vicky cane sugar? Why Oma sugar?
Should be
Oma sugar
controlled diabetes for this.
Yeah.
Your sugar should be fully controlled to make sure.
Guys, we want to know anybody out there for questions. Thank you for joining us. Come on, let's hear from you guys. It's exciting. Hello. Any other question?
Yeah.
I'm going to phone him directly when I have a question. I have more than ever.
No problems at any time.
Yeah, but look, Dayaram, it's really a nice video presentation. It's really, I think, diabetic. I always say that most of the problem with the diabetic that they're not getting good services, and everything that they know. But sometimes there's a role of every specialties in management of patients. And I think we as a physician, sometimes we're very guilty because we kind of very busy and also life get busier. And sometimes when you tell the patient you need to see ophthalmologist, they go like, I'm okay, I can see. I don't know how Canada costs a lot of stories, but they still benefit, I think, especially when they're in the hospital. So perhaps there shouldn't be an excuse why we shouldn't actually screen them while they're in the hospital. Because for myself, I don't use the what's called ophthalmoscope anymore. I think the last time I hold one was almost 10 years ago. So I don't do that anymore. But I think obviously the value that I gain with diabetic, it's not that because you're looking for diabetic complications, but also most of diabetic, they have underlying immunosuppression. They could have extra CNV, they might have other problems. They can have even like micro impacts because of the diabetes. They can have dysrhythmia, a lot of other issues. So you might actually end picking something that's not related to that. And the issue with diabetic, that patients tend to learn helplessness, means they tend to accept things as being normal. And sometimes if the vision, if not looking very well, you just get used to it. If you can't read at night, then you read during the day. They avoid driving, a lot of other issues. So sometimes it's better let's assist them quite earlier because they have no knowledge and see that they actually seen by ophthalmologists. What's your waiting periods when they have to come from the ward? Do you see them the same day,
I see them the same day or within 24 hours.
Within
If
24
I'm in theatre, I may need to see them within 24 hours.
But can they go to your
obviously-
rooms for assistance, just
Yes,
the seat,
yes,
then they go
yes,
home?
Yes, we touch base with them immediately. I'm trying to see if I can find this portable retinal camera device that's working.
Guys, I think there's some food here. Is that ours?
Yes, it's for you.
Thank you. Oh, is that a good food for diabetic anyway? I'm just asking.
Some of it is you can just take out the carbs part of it and then eat the non.
I'm not diabetic. I couldn't say all the
I'm diabetic by. I'm having that.
Oh, this is okay. This is not Google. I thought Google was typing. Okay. Let's see.
Yeah, okay, yeah,
Maybe what you want.
you're good.
Mm.
Must start looking about Monday to Monday, all after the 17th.
And then
I think test cases. Then that's what we think.
Oh, there's it. There's it. So this is a 3D printed device that you can hook up to your phone, and you just need to dilate the patients, and then you just take a picture. That's basically it. There was a company supplying it in South Africa, but people have a 3D printer. It's quite easy to make. The lens does it. We purchased
It depends on your background.
of 3D printing, doctor.
Well, yeah, it's the whole design of the measurements.
Yeah. But you can download that. I think you can ask for it.
I think you can fix it, guys, with them.
Perfect.
Because,
Okay.
yeah, so we'll share the podcast with you tomorrow. You know where to find the podcast. You can always share on your
Yeah,
website.
Thank you, everybody.
please
Thank you.
rest of